Catheter-associated urinary tract infections, engineering solutions, and clinical interventions. Hospital-acquired infections, and specifically catheter-associated urinary tract infections, are demonstrated to be a global concern. Techniques to prevent and reduce catheter-associated urinary tract infections, both from an engineering and clinical perspective, are being researched to mitigate infection. Antimicrobial surfaces is one engineering area studied to reduce biofilm formation in catheters. In the urinary tract, the binding of bacteria to bladder mucosa normally triggers the shedding of some of the urinary tract lining of barrier cells alongside the bound bacteria. A catheter device surface covers a natural surface, providing a substrate on which bacteria can easily stick and remain. While the shedding technique is not mimicked, a silver alloy hydrogel-coated urinary catheter has been found to decrease catheter-associated urinary tract infections by up to 45%. This figure demonstrates how silver ions, with their antimicrobial properties, are appropriately released by the hydrogel to minimize bacterial adherence. While silver alloy hydrogel-coated urinary catheters are effective for short-term catheter use, it only delays the onset of bacteriuria for long-term catheterization. A clinical package of strategies called infection prevention and control strategies are used to prevent hospital-acquired infections and reduce antibacterial resistance. This package of strategies varies from one intervention to another, but are generally characterized by voluntary participation of the hospitals involved, the use of a standardized system of case definitions and protocols, targeted intervention for high-risk patient populations, risk-adjusted comparison of infection rates across hospitals, personnel training and resource support, and a system of communication for feedback among healthcare providers. Standardized infection prevention and control, though flexible, has been shown to be effective in HAI prevention and antibiotic resistance reduction. For example, after the introduction of an infection prevention and control strategy in a neuro-ICU in Moscow, Russia, the proportion of invasive isolates of Klebsiella pneumoniae and Acinetobacter baumannii resistant to carbapenems decreased 1.7 and 2-fold, respectively. The image on the left is Klebsiella pneumoniae, and the one on the right is Acinetobacter baumannii. Both types of bacteria can be found in the urinary tract. The Moscow IPC, focusing on hand hygiene and patient isolation, helped reduce their resistance to carbapenems, an antibiotic commonly used for severe or high-risk bacterial infections. The two bacterial species mentioned are not the only ones which can cause urinary tract infection. In fact, UTI-causative bacteria vary among countries due to geographical variation and antibiotic use. This table shows the most common bacterial species found on medical devices, leading to an infection in the listed city or country. Bacterial species data can be helpful in determining antibiotic use and appropriate intervention strategies. Global surveillance of CAUTI and the use of resulting data to develop engineering and clinical solutions will aid in global efforts to combat biofilm-related infections. Global surveillance of CAUTI and other hospital-acquired infections is important for sharing knowledge internationally, lowering healthcare costs, improving patient treatment, recognizing new problems, and monitoring infection rates to recognize new issues will improve quality of life the world over.